Hello, everyone, and welcome. My name is Tess Taylor. I'm a specialist in the Community Education Department at MDA. We're thrilled to have you join us for today's webinar, Updates in Research and Treatment Options for Pompe Disease. This learning event is part of our larger MDA Community Education Program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the Community Education section on mda.org for updates on upcoming events. We are recording today's event and we'll be posting it to the website for on-demand viewing at a later date. If you are joining us live, please note that all phone lines have been muted, but we are looking forward to your questions today. We'll have a Q&A session at the end of the webinar with today's presenter. Feel free to type your questions in using the chat and as you think of them, and they'll be addressed after the presentation. MDA would like to thank our sponsor, Amicus Therapeutics, for partnering with us to bring you today's webinar. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, care, advocacy, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. MDA funds projects through the drug development process, from early discovery through translational stages, and infrastructure support for clinical trials. MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy work focuses on support for accelerated approvals in novel research, access to healthcare treatments, independent living, newborn screening, accessible air travel, and more. This focus plays a vital role in shaping the laws and policies that support the needs of people living with rare neuromuscular disease. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. In 2023, we offered over 40 educational programs, over 20 summer camps, and dozens of other community activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registration is free. Please see the link in the chat. For more information about MDA, please visit mda.org. Now it is my pleasure to introduce today's speaker, Dr. Urvi Gautam Desai. Dr. Desai is the director of the Carolinas MDA Care Center, Adult and Pediatric, and professor of neurology at Wake Forest University School of Medicine. She obtained her graduate medical degree at MS University, India, followed by residency in neurology and fellowship in neuromuscular disorders/EMG at UNC Chapel Hill. She has established subspecialty physician and allied health team collaborations in multidisciplinary adult and pediatric MDA clinics at Atrium Health. She is the recipient of the MGFA Partners in Care and CMT/HNF Center for Excellence, as well as the Researcher of the Year for Atrium Health Neurosciences Institute Awards. She serves on the advisory board for the North Carolina site for MD StarNet, a CDC-funded network that conducts public health surveillance of muscular dystrophy. She is a member of GRASP, the Genetic Resolution and Assessment Solving Phenotypes LGMD Consortium. Her research interests include overlap of sleep and neuromuscular disorders, and she serves as the principal investigator for multiple clinical trials in myasthenia gravis, CIDP, Duchenne muscular dystrophy, spinal muscular atrophy, hereditary TTR amyloidosis, and limb-girdle muscular dystrophy. Dr. Desai, thank you so much for joining us today. We are looking forward to your presentation, and I will now turn the time over to you.
Thanks, Teresa, and thanks everyone, especially MDA, for inviting me to give this talk today. We are going to focus on Pompe disease. We'll talk a little bit about the some basics of the disease, and then move on to what is new, what is recently available, with some background. So these are my disclosures. What is our agenda today? As I said, we will talk briefly about the clinical presentation of Pompe disease, and we will have an overview of the current treatment landscape updates in the research and the clinical trials in Pompe disease. So our goal is to ensure that individuals who suffer from Pompe and or their caretakers have up-to-date information and what are the care considerations regarding this disease. So, as we know, Pompe disease is a rare, progressive, disabling, but multi-system disease. It affects not just the skeletal muscles, but the heart, the brain, the respiratory system, etc. So it's very important for us to understand that it is a multi-system disease. And how does the history go? That in 1932, a Dutch physician named Pompe, John Pompe, he observed that there was a glycogen storage in a 7-month-old child who developed muscle weakness and then eventually died from heart failure. And then 1963, Hers discovered an enzyme called acid maltase or GAA, and it established the correlation with Pompe disease when the glycogen storage was found in the muscle cells. So this is a metabolic disease, and it is also known as a glycogen storage type 2 disease. As you can see here, the pathology in Pompe is the accumulation or storage of glycogen in the cells. And there are different ways we can assess this on muscle. We're doing it less now because we have other testing available. But as you can see here, especially on the right-hand side, as you can see here, that this biopsy shows this intracytoplasmic within the cells, what we call as the rimmed vacuoles. And then there is a special stain called PAS stain, which shows that there is accumulation of glycogen. If we look at the genetics of Pompe disease, as you can see, it is an autosomal recessive disorder. So this little cartoon helps to understand that a dad is a carrier and a mom is a carrier. They are not suffering from the disease manifestations or symptoms. And then there is eventually around 25% chance for the baby to develop the disease if the baby inherited both copies of the abnormal gene. So, and the GAA gene is located on chromosome 17. Now, we have almost more than 634 mutations so far, but we should understand that this is a monogenetic disease, meaning a single gene produces, if there is mutation in a single gene, then it produces this disease. So the GAA gene, it provides instruction for making an enzyme. The name of the enzyme is called alpha glucosidase or acid maltase. And this enzyme is very important to break down complex sugar, glycogen into glucose. So if it doesn't break down glycogen into glucose, then eventually there is a glycogen accumulation or storage in the cells, which causes the cell damage. And there can be many different type of genetic variants. Usually point mutations can lead to this abnormality within the gene. Sometimes there is small and large deletions or insertions. But we again need to understand that the pathogenic variants in both copies of the GAA gene is needed for this inheritance, and one each derived from each parent. So what is the pathophysiology of this disease? So we just talked about that there is a partial or total deficiency of this enzyme, and then that leads to increase in the cells, or what we call intralysosomal glycogen accumulation, and that leads to the rupture of the lysosomal membrane. So as here, as you can see, this is a normal cell. You have a presence of GAA, which then helps to break down glycogen into glucose. But if that doesn't happen, then you have the accumulation of the glycogen. And then when the glycogen builds up, it really affects the muscle cells and other cells as well. So lysosomes are kind of recycling molecules which degrade and recycle proteins and smaller organelles, and so keep the cells healthy. And when that doesn't happen, then you do have deposition of this abnormal tissue, abnormal glycogen in the tissue like muscles or heart or brain, etc. Now, as we also know that Pompe disease has a phenotypic spectrum, meaning it presents in a slightly different way. One is an infantile form, what we call as a classic or infantile onset Pompe disease. The other one is a late onset or a non-classic form of the disease. And it's very important to understand the difference between these two forms. So in the infantile onset, you have this enzyme, the GAA activity is totally or almost virtually absent, almost less than 1%. So most of these patients present before the age 1 year. And typically, if we look at the data, the median age of presentation is around 2 months, and it sometimes can take diagnosis to be delayed by a couple of months also. So the median age one study showed was diagnosis around 4.5, 4.7 months. These patients survive without the treatment around 8 to 9 months. So this is a much more severe form than late onset Pompe disease. We also need to understand that there is called CRIMS, or what we know as a cross-reactive immunological material. And what it means that patients who have some kind of GAA activity, they are CRIM positive. They have already exposure to some of this enzyme or activity. And so they would respond better to the enzyme therapy, but there are CRIM negative, meaning patients who have absolutely no activity of this enzyme. And then when we introduce the gene and the enzyme therapy, they become intolerant because then they produce an immune response, they produce increased antibody production, and they need to be treated with some other medications to calm down the immune system. Talk more about it later in the talk. So the infantile onset patients have symptoms of delayed motor milestones. They're very hypotonic, they're weak, their heart is enlarged, their liver is enlarged, they have a large tongue, and then they have significant respiratory distress and difficulty breathing. If we look at the late onset, here the GAA activity can range from anywhere from 1 to 40%, and this patient is present after age 1 year. It can occasionally present before the age 1 year, but without the cardiomyopathy in these patients, which we see in the onset. The patients can present at any age up to like first to sixth decade and even later. So it's very important for the general neurologist and the neuromuscular community to be aware of this possibility when the patients present with weakness, failure. We should also know that these patients sometimes can have CNS abnormalities, and the death typically occurs because of the respiratory failure. So when we talk about the treatment considerations in Pompe, we need to understand that this is a complex disease. We talked about how multi-system involvement occurs in Pompe. So we really need a multidisciplinary care team. So in addition to the neuromuscular specialist, you also need to have a geneticist on board. We want to have metabolic physicians. And in addition to that, we want cardiologists, pulmonologists, especially the allied health team, the physical therapist, the respiratory therapist, the social worker to navigate a lot of challenges, speech therapist, and also the mobility support personnel. So in addition to this type of supportive care, we do have some pharmacological treatments available in Pompe, and we know the enzyme replacement therapy or ERT. So the ERT was studied as early as 1970s in infantile Pompe disease, and we should understand the regimens are a bit different between infantile onset and the late onset. In infantile onset, we should start enzyme replacement therapy as soon as possible. In late onset, we have some treatment guidelines, and recommendation would be that we monitor these patients every 6 months and make sure that they're not developing any weakness. And if they do, then we start the enzyme replacement therapy as soon as possible. The cardiac monitoring is very important in these patients, as we know that the heart very commonly gets involved because the glycogen can also accumulate in the heart cells. And heart then becomes enlarged because there's a glycogen in the heart cells. And in the beginning, you will have what we call as a hypertrophic, meaning the enlarged heart. And then later on, that heart can become more what we call as a dilated cardiomyopathy. There is a heart failure. There can also be irregularity of the heart rhythm because of the glycogen infiltration. And one thing that we need to keep in mind that when we start the patients on enzyme replacement therapy, the heart mass, because the heart can become smaller, right? It becomes hypertrophic, becomes bigger with the glycogen accumulation. So when the glycogen accumulation reduces, the mass of the heart reduces, and that can cause in the beginning some irregular heartbeat and cardiac arrhythmia. So important that these patients get 24-hour EKG, which is like a Holter. So in a nutshell, a timeline of the research trials, and I started from 2001 because we need to understand what happened in the very beginning, how the enzyme replacement therapy came in the picture. And as I said, the data and the collection of the clinical trials, the phase 1 trial was in 2001. Then gradually the trial included in 2006 for the infantile onset, and the enzyme therapy got approved the first time in 2006. In the 2010, it was for late onset. And then there are further trials went on. There is a beta block agonist trial in 2018. And then we had the glucosidase trial and the combination trial with chaperone therapy. Again, these are the one that we talking about, started in 2019 for late onset disease. And there are some ongoing trials of infantile onset as well as gene therapy trials going on. And then there are some other avenues of the treatment considerations in these patients. So what is the rationale of the enzyme replacement therapy? What we want to do with this is that we want to give patients the working version of this GAA enzyme so that can replace the dysfunctional enzyme, which is not doing anything, and letting glycogen accumulate. It is also important to understand, and this is a little bit difficult concept, but that these enzymes need to get into the cells, right? So that's called trafficking to lysosome within the lysosome within the cells. And the trafficking or entry of this enzyme, the new enzyme, into the lysosome occurs by some receptors. The receptors are like gates on this membrane of the cells, and they are called mannose 6-phosphate. So mannose 6-phosphate receptors, if those receptors can bind to the enzyme at much higher affinity and a strength, then you can bring more enzyme into the lysosome. So we will talk a little bit more about that, but just as a baseline, we want to understand the role of these mannose 6-phosphate receptors. So as we talked about, the first therapy that got approved in 2006 for infantile onset was glucosidase alpha. And we know that helped to improve the cardiac and the lumizyme. And we know that they improved the cardiac and the respiratory function and the muscle strength. It extended the lifespan of these patients and changed the phenotype of these infantile onset patients. In the very beginning, we talked about how these patients were so weak that the death was around 8 to 9 months, and now we have a completely different phenotype of these patients. We should also remember that these patients develop neutralizing antibodies to this new enzyme because they produce this immune response depending upon whether they do have underlying enzyme activity or not. So again, remember we talked about this CRIM status or a cross-reactive immunologic material status, meaning the ability to make this enzyme. So patients who are CRIM negative, meaning that they do not make any of this enzyme on their own, and the CRIM positive makes some enzyme. Still, it is not functioning enough. So patients who are CRIM negative, because their bodies cannot make this enzyme that they get in as an invader, and that leads to an immune response which can interfere with the enzyme replacement therapy. And that's why they need what we call as the immunosuppressants in the beginning. So sometimes they get they get IIG, Velcade. These are the different medications that we have to prime patients with to prevent the formation of these antibodies and further damage that can occur in these patients. We also need to understand that these patients who are on enzyme replacement therapy would need lab monitoring very closely. We need to check their muscle enzyme. We need to check their liver function test. We need to check the antibody titers, and we check something called urine hex4. Hex4 is a hexose tetrasaccharide test, and that we can measure in the urine because it is a biomarker of the glycogen storage. So if it is high, then it tells us that the patients are not responding as well as they should. So basically, it is a biomarker for Pompe disease. So the first therapy that got approved, very briefly, we talk about it. It was approved patients who received this therapy. The trial was in age 5 to 6 months. And they noticed that earlier intervention it much better to give these patients as soon as possible. It improved the motor milestones, the cardiomyopathy they had, which was much improved. They were able to reverse it. The survival got better, so patients could survive up to 18 months at least in 100% of the cases, and reduced risk of requiring ventilation. But went along this year, there was definitely the difference between the treatment arm versus a non-treatment arm in the 6-minute walk distance or a forced vital capacity. But as we move further, we noticed that there was a clinical plateau and then subsequent decline after around 20 to 24 months. So the cardiac benefit was sustained, but not the other benefits. And patient continued to develop progressive muscle weakness. Almost half of the patient did not learn how to walk. And they continued to have respiratory decline and ventilator-free survival, meaning not needing the ventilation, dropped by 50% at age 3 years. And they also develop other difficulties like difficulty hearing, speech dysfunction, some cognitive impairment, GI issues, etc. It was also evaluated in the late onset Pompe, and a study that looked at the 10-year follow-up in 30 patients showed that around 90% of the patients initially benefited, but then continued to show slow linear decline after 3 to 5 years, and around 17% had continued positive response after even 10 years. So there was a subset of the patient who did well, but 7% were non-responders from the beginning. And even within the responders, there was some discordant among patients. So some patients who did better on the motor strength did not do so well on the respiratory strength, and vice versa. And around 7% developed severe infusion reactions. So what are the factors that impact this enzyme replacement therapy? We already talked about the screen status, right? The development of the bodies, also the age at the onset, what is the degree of the irreversible muscle damage when we start the treatment, and the clinical status at the start of the treatment. So these are the things to keep in mind, that even though you start the enzyme therapy, these are the factors that can impact the efficacy of the therapy. So let's move on to talk a little bit more the newer areas of development, which are some approved, some in the process of approval, some in the trials, etc. So there are different varieties and treatment strategies for Pompe that we can think about. So the figure here, for example, shows that what we can do is enhancement in the enzyme replacement therapy and newer versions. And remember, we talked about this MPR receptors, the phosphate receptors, and if we can combine this enzyme with more receptors that bring the enzyme quickly into the cells, would be much better. We can improve the efficacy of this enzyme replacement therapy. There are a few other mechanisms. One is called inhibition of GYS1, and I'll talk a little bit more about it later on, which helps to reduce the glycogen accumulation. There are lysosomal exocytosis, so how we can bring the lysosome to the cell surface and just get rid of the glycogen, and then eventually the gene therapy. So there are different approach the new therapies or research in Pompe. So if we look at the enzyme replacement enhancement strategies, one thing we can do is we can increase the dose and frequency. For example, in infantile onset, one can go up to 40 milligram kg of weekly aglycosidase alpha. In CRIM negative, we talked about the immunomodulation and immunosuppressant therapy. Occasionally, there have been reports of doing exercise during infusion to increase the muscle uptake. There was a trial called clenbuterol, which is a beta agonist, and one of the trials is still ongoing. There are next generation replacement therapies to improve the muscle-specific uptake, and one very much important that we already have talked a couple of times is the increase in this receptor tagging. So increase this mannose-6 phosphate receptor tagging. Utilizing other uptake mechanisms, and then chaperone therapy, which you can use in conjunction with the enzyme replacement therapy. So the next generation enzyme replacement therapy, we have two: evaglucosidase and cipaglucosidase alpha plus miglustat. These are very tongue-twisting pronounced, but you all know that even the branded names are also somewhat difficult to pronounce. So both of these compared the studies, the standard of care, which was aglycosidase alpha enzyme in Pompe and Propylene. I'll talk a little bit more about those trials. Both were published in December 2021. And we should remember that neither of them showed to be superior to the standard of care product, but they were also not inferior. So let's talk a little bit more in detail of what we call as evaglucosidase alpha or nexviazyme. So this is a recombinant human M6P enriched enzyme therapy. So again, this is the receptor tagged therapy. And we know that all enzymes enter the cells via this receptor. And if it is the receptor binding, then there will be increased uptake of this enzyme into the cells. And this product has a 15 times more increase in the level of this MC6P compared to aglycosidase. So here, as you can see in this cartoon, that the enzyme is tagged with this M6P, and so it is easier for the enzyme to go through the receptors because there will be increased receptor binding and then entering into the cells where the enzyme can dissociate the receptors from the enzyme. So it is important to understand that if we increase the tagging or the binding with these receptors, then there is increased entry of the enzyme in the cells, and so that is a more effective therapy. So in preclinical models, when they studied evaglucosidase alpha, they showed that there was a 5-time increased glycogen clearance from the cells, and there was improvement in the motor functions. And so they did what they call as a phase 1 trial or NEOX trial, and this was in the patients who had not received any enzyme therapy, and also patients who had received enzyme therapies, and they showed that there was a stabilization in their respiratory and motor function up to 6 years of treatment. So that indicated there was a better benefit, and so that moved on to this phase 3 COMET trial. The drug was approved in August of 2021 for patients with late onset Pompe at 1 or more than 1 year of age. So the COMET trial looked at the safety and efficacy of evaglucosidase alpha versus aglycosidase alpha in patients with late onset Pompe. So the age was 16 to 78. They were treatment naive, meaning they had not been on previous enzyme therapy. Their was ability to breathe properly, and there is a respiratory assessment that we do. They should have been able to walk at least 40 meters without stopping or using a device. Their 6-minute walk distance should have been 118 to 600 meters. And then the outcomes that they looked at was at 49 weeks, change in their FVC, the respiratory parameter, or secondary outcome was change in their 6-minute walk test. And they looked at a lot of other motor outcomes as well as biomarkers that we just talked about, the lab work, the HEX4 or CK, etc., then the safety. So they enrolled around 100 patients and then randomized into patients who were on the treatment arm, and then the patient on the newer treatment arm, then the patient who was on alpha. This was a double-blind analysis, and then they did the open-label extension up to week 145. So if we look at the results, it showed that this is a treatment arm, and this is not the treatment arm. This was the evaglucosidase, and this showed that there was improvement in their FVC, in their respiratory parameters, and the treatment arm was versus 0.46% on the aglucosidase. So that means that there was a 2.43% more increase in their forced vital capacity, a pulmonary breathing measurement. When they looked at the 6-meter walk distance, again, there was a difference, but around 30-meter difference in the treatment and a non-treatment or standard of care arm. So it showed that there was, they achieved non-inferiority, but if we look at the statistical model, it didn't appear to be superior. When the open-label extension trial went on, they showed that the patient walked 30 meters further than not. The safety profile, the infusion reactions, if you look at in patients who were receiving evaglucosidase, were around 25% versus aglucosidase around 33%. The severe infusion reactions were 0 in evaglucosidase versus 4% in aglucosidase. And the serious adverse reactions were 2% in evaglucosidase and 6% in aglucosidase. And there are different reactions, as you can see here, with headaches and fatigue, diarrhea, etc. So let us move on now to talk about chaperone therapy. So chaperones can work by boosting the stability and the functionality of the enzymes. So they are small molecules and they can bind to dysfunctional enzyme, helping it to fold correctly, because we need to understand that for the enzyme to work, it has to fold properly in a specific 3D shape. So chaperone helps to do that, and that's how they boost the stability and the functionality of the enzyme. So one can use this chaperone molecules as complementary approach to the enzyme replacement therapy, in which the chaperone can bind to the functional enzyme, like for example, the enzyme that you are giving in combination. So the new medication that we are going to talk about, the epaglucosidase alpha, which is an enzyme, which then is combined with miglustat, which is the chaperone, which helps to stabilize this enzyme, and so even increases the effectiveness of this enzyme. But you can also give it as an independent therapeutic approach that is still being investigated at this stage. But we should understand that it wouldn't work on its own alone if the patients have no enzyme, right? So since if there is no enzyme, chaperone have nowhere else to work. So around 10 to 15% of the patients may not benefit from this therapy alone in isolation. So the epaglucosidase alpha and miglustat, the combination therapy, it is approved for the patients with late onset Pompe who weigh at least 40 kg and who are currently not improving on their current enzyme replacement therapy. That is the indication from the FDA approved indication. So the epaglucosidase is again a recombinant human enzyme, GAA enzyme, but it is enriched with this. Again, remember we talked about these mannose-6 phosphate receptors. So it is enriched with that to improve the binding affinity, and it is almost 3,000 times more affinity than the aglucosidase. So that improves the cellular uptake, and then it gives the very active form of the enzyme to the cells. In addition to that very active and very effective enzyme, miglustat, in addition to that, it's again, as I talked about, it's a chaperone, which is an enzyme stabilizer. It stabilizes this zipaglucosidase, prolongs its half-life, and increases the amount of active enzyme available to target glycogen in the lysosome. So there was a trial called Propel trial that looked at the safety of this drug and efficacy of this drug. It was evaluated in patients with late onset disease, more than 18 years of age, more than 40 kg. They looked at both type of patients, the patients who were on a previous enzyme replacement therapy, around 80% of those, and the patients who were naive, meaning had no enzyme replacement therapy. If they were on enzyme replacement, they had to be on it for more than 24 months. For 52 weeks. They enrolled 123 patients, and then they again compared them with the combination versus placebo, and then looked at their FVC and 6-minute walk as their primary outcomes. But we should know that the patient should have had more than 30% predicted, meaning that they were not needing any mechanical ventilation for more than 6 hours a day and were able to walk unassisted. So if you look at the study results, as you can see here, again, there's a separation of these patients who were on the treatment arm with versus the standard of care, which is aglucosidase. And in the 6-meter walk, there was a 20.8 meter change from baseline to 52 weeks versus 7.2 meter change when they were just on a standard of care. The breathing, also, there was a mean improvement by around 3.5%. If we look at that, 17% improvement in the 6-meter walk. And the muscle enzyme in the S4 levels, there was a significant reduction by around 30%, while patients had increase in 20%. So again, the results did show the improvement, but again, statistically, it did not achieve that superiority to the standard of care, but there was evidence that there was a potentially clinically meaningful improvement in their 6-meter walk, which is a motor function and a respiratory function demonstrated by the FVC. So if we summarize, the patients who were treatment naive, they were not better than standard treatment therapy, but the combination showed that the patients who were not on a combination, but just on a standard of care, showed no improvement in the 6-meter walk. In fact, they showed the reduction by 4% in their FVC at 52 weeks. And the patients who switched, they did better by around increase in the walking of around 6.9 meter, the 6-meter walk, and had a stable FVC. So they also showed that the combination therapy actually showed that if they were getting better, then they showed the improvement as early as week 12. But they continued to improve, and the greatest improvement was seen at week 52. Other factor, as we know that in Pompe, with the standard enzyme replacement, we are concerned that there is a clinical plateau effect. Here, at 52 weeks, the 6-meter walk did not plateau. That means they continued to do better. So there is a potential that further improvement is possible in these patients. And the open-label extension study will give us more data. The safety here, as you can see, then the combination versus the standard of care, and most of that very comparable, with a slightly higher headaches and diarrhea, dizziness, etc. So how do one take this medication? So they have to take the pre-treatment with antihistamine, antipyretic, and or steroids. And then the miglustat, the enzyme stabilizer, should be taken at least an hour before the IV infusion of the enzyme, the zipaglucosidase, after 2 hours of fasting. And they can stop the fasting 2 hours after. but it is contraindicated in pregnancy. So if a pregnant patient is going to, a female patient is going to use it, they have to use the contraception. So it's very, very important. And I'll just give you the name of this medication. It is I think we talked about it, but the miglustat is Opfolda, and the sipaglucosidase is Pompe. And as we know that it has been approved with that specific indication. So now let's switch gear from the current enzyme replacement to substrate reduction, meaning we know that in Pompe there is buildup of this toxic glycogen, which causes the damage to the cells. So what can we do to reduce glycogen? One is, of course, we are giving the enzyme, but can we block the production of glycogen? And so there are two companies, one is Mace Therapeutics and another is Aero Therapeutics. They are doing two studies. One is called MCE001, is an oral glycogen synthase inhibitor. So this glycogen synthase or GYS1 enzyme is responsible for the glycogen production. And so if we prevent the production of the glycogen fat, even if you don't have the glycogen, the GA doesn't have to worry that it's not able to break down the glycogen into glucose. So it is even the upstream, meaning even before the glycogen is produced, we are trying to block it by inhibiting this enzyme which produces the glycogen. So again, the MCE001 and then ABX1100. The ABX uses a compound called ABX1100, which is a small interfering RNA, or what we call it as, it reduces basically the levels and activity of this GYS1 enzyme. What else we can do is that we can do something called lysosomal exocytosis. So if we can bring those lysosomes closer to the cell membrane, and then it can dock at the membrane of the cell and then dump its cargo, meaning the excess glycogen, outside of the cell. So because we know that the lysosomes act like recycling centers, facilitating the breakdown of glycogen. So if you can just bring it to the cells and then dump it outside in the extracellular space, that is a potential therapeutic option. Again, this is another way to see if we can get rid of that glycogen. But the most promising therapy now is the gene therapy, and there are some gene therapy approaches in Pompe being investigated at this stage. So there's something called in vivo gene therapy, where you can directly administer a gene via vector, vector meaning something that transports the good copy of the gene into the patient's body. They could be viruses that you can package, tiny viruses with this gene product. They could be non-viral as well. And then you can inject that directly into the bloodstream. You can inject that into the liver, into the muscle, or even the ventricle. There are tiny spinal fluids filled spaces in the brain to target the CNS. That is called in vivo gene therapy. Ex vivo is something that you are trying to modify the patient's cells, and so you take out their cells from the bone marrow, and what we call is a hematopoietic stem cells, or they are CD34 cells, and then what we do is that we change those cells with a good gene so that it goes back into the body and then produces a normal enzyme. So the systemic gene therapy, the in vivo therapy that we talked about, so the whole idea is that you want to introduce a functioning copy of the gene, and this new gene is delivered by a vector into the cells. And then once it is entering into the patient's cells, then it is transcribed and translated to produce this enzyme. As in the beginning, as I said, that Pompe disease is monogenetic, meaning it is a single gene that produces this disease. And so it is easier to target the gene therapy because it's a single gene that we need to find a better copy of that. And it has a potential that it can treat multiple systems based on where you inject. And there are some challenges, however, we have to find a vector which is not going to be producing any infections, which is not going to incorporate into the patient's genome, etc. Also, there could be immunological response, and what happens about the redosing. Do we give the gene therapy one and done, or we will need to do that? So there's a lot of questions going on. In this cartoon, as you can see, that this pink is the enzyme replacement therapy. So once you give it, the enzyme activity goes up, but then it comes down. Even if we give it with a chaperone, it does better, but still it comes down. Gene therapy has a potential that once you enter it and it produces a normal enzyme, then it has a consistent response, as you can see here. So definitely is quite attractive option for patients. So there are many gene therapy trials going on. I have listed some here. There is one which is looking at the evaluation safety in the late onset. And these are you will have this this presentation for you to refer later on, but I have put here the clinicaltrial.gov tag number here for this trial. There is one which is expected to be completed in December 2026. There is and just started in April 2024. There's another one which is looking at the infantile onset. There are this both look at GC301, which is the viral vector, adenovirus vector gene therapy. The 40s is for the late onset Pompe, and it is an ascending. So they're going to look at different doses. Again, it is a vector base, but in adult patients, so they are going to be more than 18 years old. So far, 4 patients have been treated, and 3 of them have been able to stop the enzyme replacement therapy. Another one called Resolute is a single infusion of a compound called SPK3006, again in adults with late onset Pompe. And then there was Actus 101, not recruiting currently, but safety and bioactivity in late onset. So there are a lot of options in the gene therapy trials going on at this stage. So remember, I talked about in the beginning that when we had patients who had a very severe disease, but we started giving the enzyme replacement therapy. So we have changed their phenotype. They look different than how they looked before, but they still have significant morbidities. Still, they have a significant weakness, hearing loss. They can develop ptosis, muscle weakness on the face, speech difficulties swallowing, cardiac issues, white matter abnormalities in the brain. Sometimes the smooth muscles get involved of the blood vessels, so they can develop aneurysms. They can accumulate the glycogen in the brain, and that can cause the hearing loss and learning difficulties. So we really need to remember that as we treat these diseases, we are changing the phenotype, and one needs to be very much aware of these possibilities, that what else we can do. And as we discussed, there are a lot of options coming through the pipeline, and so it's a very exciting time at this stage in neuromuscular disorders. But there are still some unresolved questions in Pompe. So the question is, what is the optimal time to start disease-modifying therapy, especially in the late onset patients? Should we wait till they start developing the weakness or manifesting the weakness? How to delay the disease onset by use of strategies like substrate reduction. We talked about how we can get rid of prevention of glycogen formation. How do we prolong the effectiveness of enzyme replacement so they have a much more stable enzyme level? How do we better deliver the enzyme to target organs like muscle or heart or brain? How we mitigate these neutralizing antibodies that we know are being produced in the response of the enzyme replacement therapy antibodies, then reducing the effectiveness of the therapy. How do we mitigate the vector antibodies in gene therapy? Because those vectors, so that they may be not infectious, the body produces antibodies against them, and if so, then they would reduce the effectiveness of the gene therapies. And how do we develop more sensitive outcome measures? Is the assessment of breathing tests and looking at the function of FVC is good enough? or looking at the 6-minute walk is good enough. So how do we measure very sensitive outcome measures for the disease progression so that we can incorporate that in clinical trials and monitoring the patients? So I'm going to end here stop the screen 1 second. And
yeah,
able to take any questions.
Wonderful, Dr. Desai. Thank you so much. We do have just a few questions in the chat if you have time. Our first question was, are chaperone medications available for all ERT medications?
No. So at this stage, it is just with the sipagliflozin combination therapy that we talked about.
Okay, great. Thank you. Our next question was, do you have any idea when gene therapy will be available as a treatment for late onset Pompe patients?
So I'm hoping that we will know something by that trial that is going to be completed by December 2026. If there are other avenues, I mean, there's so much going on in this field, and I may not be aware that there is something going on in other countries, then, that may bring some other options to us more quickly, but it's hard to answer. It's a moving target. But the target is definitely going to the right place, and so hopefully we will learn more and more.
Wonderful, thank you. Our last question that we had pre-panel was, how common is, if a patient has had a reaction to Lumizyme in the past and decides to go off of that medication, should that patient keep their same pre-medications or pre-treatments that you were talking about, such as the antihistamines and steroids?
Yeah, I would suggest that you talk to your treating physician and see what happened with that reaction. But it is extremely important that the patient be treated appropriately, so to make sure that there is no infusion reaction. And there are these different avenues. Again, it depends on why the infusion reactions occur. What was the cream status? Whether there were any antibodies? What was the degree of antibody elevation? So I can't advise in that direct fashion, but I think it would be good to talk to the treating physician because there might be other avenues available.
Absolutely, yes. Well, thank you so much for your input. We do want to make sure that we let you go on time, but we thank you so much for your appreciation, for your time, and for your expertise and support of the neuromuscular disease community.
Thank you. I love being a neuromuscular neurologist. I think we are in a wonderful phase. And I also appreciate that MDA is really trying to help patients with these disorders in multifaceted ways. So thank you as well. And thanks for everyone who was listening and taking the time to come and listen to this topic. So thank you.
Thank you. Thank you for joining us today.
Bye.
It was very informative.
Thank you. Bye.
Bye. So if you are new to MDA and have been diagnosed with a neuromuscular disease under MDA's umbrella, or if you are a loved one of someone who is diagnosed, we encourage you to stay engaged with us at MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. MDA has ongoing webinars, virtual learning programs, and live events that may be of interest to you. Be sure to check out our webpage frequently by scanning the QR tab at the right of your screen. MDA would again like to thank our sponsor, Amicus Therapeutics, for partnering with us to bring you today's webinar. We would love to hear your comments about today's webinar. Once you leave, a web page will automatically pop up with a short survey about the webinar. Completing the survey will provide us with important insight as we plan for future educational programs. If anyone has questions after this webinar, please feel free to contact MDA's Resource Center at 1-833-ASK-MDA1 or email our Resource Center at resourcecenter@mdausa.org, and we will be sure to get back to you. I want to thank Dr. Desai again for her time, and thank you to everyone who attended. This concludes today's webinar. I hope you all have a great evening, and we hope to see you again soon.